short period of time. Like the previous time, same venue, team of expert doctors from the same hospital, same audience, and keeping the synchrony, I am wearing the same coat. So I'd like to formally welcome our guest, Dr. Murtaza Habib, Facility Director, Paras Hospital, Srinagar. Dr. Mohammad Maqbool Suhail, Director, Intervention Cardiology, Paras Hospital, Srinagar. Dr. Naeem Firdoz Dar, Senior Consultant Pulmonology, Paras Hospital. Dr. Adil Ashraf, Senior Consultant Gastroenterology, Paras Hospital. Dr. Adnan Firdoz Raina, Senior Consultant Neurology. Dr. Rahil Rafiq, Senior Consultant Neurosurgery. Last but not the least, Dr. Ishaq Nabi, Consultant General and Laparoscopic Surgery. Also, members of the management present here, Mr. Arun Sharma, AGM Marketing, Mr. Iqbal Rahmani, Manager Sales and Marketing, Mr. Mehran, DM Operations, and their associated team members. Senior consultants from District Hospital Kargils, medical officers, team from media, and other members present here. A very warm greetings to all of you in this beautiful evening where we are going to interact, learn, and enjoy. So, the collaboration between Paras Hospital, Srinagar, and Bakaria Healthcare and Research Center, Kargil, has been very fruitful for the poor people of Kargil. People may wonder at this collaboration. Am I audible to everybody properly? Yes. So, people may wonder at this collaboration, one is a pure corporate body and one is a charitable hospital. But I'd like to say this collaboration has been but natural. Because Paras Hospital, we all know, is synonymous with excellence and quality healthcare. But we saw Paras Hospital means service to humanity also. Because during our interactions with their management, especially Dr. Murtaza Habib sir and Mr. Arun Sharma, we saw they regularly conduct such kind of free camps for the poor people. They have conducted many such camps in far-flung areas of Kashmir. And this is the second camp they have been conducting within a short period of just a month. So you can imagine the service they are providing to the poor people. Paras is a Hindi word meaning gem. Paras is something, whatever it touches, it turns into gold. So Paras has been really a gem for the poor people of Kashmir, for the people of Kashmir, and now recently for the people of Kargil also. Paras Hospital has been rendering exemplary healthcare service under one roof. Paras Hospital is one single corporate hospital in Srinagar which has a 24-hour consultant-based emergency service running 24 hours, which is not available in any private hospitals in the valley. Paras Hospital, within a short period of only 2 years, the Paras Hospital was established, I think in 2023. Within a short period, they have covered all the specialties. They have all specialties, all super specialties, all kinds of medical services, all equipments, everything. Any kind of treatment, any kind of investigation, any kind of medical modality which is available anywhere in India, in any advanced hospital, is available in Paras Hospital, Srinagar. So when a patient comes to Paras Hospital, he will go out healthy and hearty, getting all kinds of treatment, doing all kinds of investigation. Whatever is needed happens under one roof in Paras Hospital. So we can imagine, because normally what happens in private setup, they just take normal cases and whatever a complex situation comes, immediately they refer to the government setup. But in Paras Hospital, they treat, they manage all kinds of complex, whatever the situation, they will tackle it. and they will treat the patient. So this is the second camp that we are doing with Paras Hospital. Previously also many specialties came and rendered service for our poor patients at the doorstep free of cost. And this time also, when we just requested them, they were ready. They said, for the people of KARGIL, we are ready to come anytime. And they have come with other specialties also. The specialties have been added. So we can imagine the collaboration that we are having with Paras has been very, very fruitful for the people of KARGIL. So now I'd like to say a few couplets in honor of the visiting doctors. I'd like to say, if God wished for all ailments to cure, if God wished for all ailments to cure, via the hands of a doctor, He made it sure. Dear to God is all humans, white or black, but who treats the sick is dearest and pure. Now this line is dedicated to our cardiologist, Dr. Maqbool Suhail sir. When that dreadful tightness in your chest flattens all your might, only in the hands of Dr. Suhail Maqbool you feel secure. I coined this line just now. So welcome everybody, sir, especially the team, our guests coming from Paras Hospital and all the doctors present here. Now I'll not take much time. I'd like to request our President, Dr. Ahmad Ali sir, to formally welcome our guest with our traditional Ladakhi khatak. And the visiting doctors will welcome with traditional khataks. Dr. Naeem Firdaus Dar, consultant pulmonology. Dr. Ishaq Nabi, consultant general and laparoscopic surgery. Dr. Adnan Firdaus Rana, senior consultant neurology. Dr. Suhail Maqbool, senior consultant interventional cardiology. Dr. Adil Ashraf, senior consultant gastroenterology. And also we will welcome the managing committee, beginning with Mr. Arun Sharma. He is AGM Marketing at Paras Hospital, Srinagar. And Mr. Iqbal Rahmani, who put lot of efforts to make this possible, this event and the camp. Thank you very much, sir. Now I will not take much time because it's already very late. So we'll begin the session formally with the interactive session with Dr. Mohammad Maqbool Suhail, Director Intervention Cardiology. He has special expertise in complex interventions. He is a proctor of intravascular imaging and rotational atherectomy. He has done almost more than 8,000 interventions. I'd like to invite Dr. Mohammad Maqbool Suhail sir to please come on the dais and have an interactive session. Our audience can ask any kinds of question related to cardiology to sir. It will not be a formal presentation, it will just be an interactive session, sort of a discussion. Please sir, Dr. Mohammad Maqbool Suhail.
Good evening everyone, and I am very thankful to Bakaria Trust for organizing and giving us opportunity to interact and serve the people with our expert opinions. So actually last time I had presented a CME, so this time I thought now in CME I speak which I want to like a topic which I have decided and discuss about it. So maybe many like doctors are here who are facing challenges in managing the cardiac patients, cardiac emergencies. So it would be better to interact and if they want to ask the questions regarding the issues in any type of cardiac emergency or cardiac issues.
हाँ हाँ Sir, I would like to ask a question. Myocardial infarction cases is especially increasing in Kargil, sir. We are seeing almost 2-3 cases every day in this small population of 1.5 lakh. I think it's very high. So, what is the reason why it is, sir?
No reason, you see now in globally it is increasing because of there are multiple factors. So most commonly now it's like the combination of multiple factors like sedentary lifestyle, diet. Now the diet the diet is not like previously we used to have balanced diet. Now because of lifestyle the physical activity has become more and the diet like physical activity is less and the diet we take the more calories and we burn less. So it's causing, and we are taking food which are which have empty calories and food which is packed processed foods. So that's one of the reason we are seeing it now in younger generations. So and smoking, it is now common in younger generation. Junk food more common in the younger generation now. So and now that's the reason now with the modernization there is these are the negative things which be one of the cardiac MIs they are now rising especially in young people.
So you are absolutely right, sir, because post-COVID, last time also we discussed that we're getting a lot of patients, and especially young people, coming with MI. Sir, I just wanted to ask you regarding the MI equivalent, especially like de-winters, should we thrombolyze those patients or not? Like de-winters we're getting at times, So how should we go ahead in such situations? Should we thrombolyze or
I think
is there any criteria for that?
Now if you have there is a clear-cut MI and de-winters are posterior wall MI.
Okay.
And if you have echo help,
okay.
If you think that like in anterior wall MI like de-winters, severe pain and you find this is hypokinetic territory, like anterior septal, then it's okay. You can in this periphery, it is better to thrombolyze.
So you mean to say that we have to go for an echo and just see whether there's any hypokinesia and something like that?
Yeah, that's an help you. So if you are sure that it's, and still if there is no sign, so you should, if you are like, you have to risk profile. If patient has risk factors and clinically its features are resembling, there is risk factors and the ECG findings is now typical. So you can, echo will be just helping you more, making it more sure.
One more thing, sir, sometimes we get a patient who has come a bit late, for instance, almost 16 hours or more than that, but patient continues to have chest pain, and we find that the ECGs that's showing an MI. So how should we go ahead in that kind of a scenario?
Any MI, like MI situation, if patient is having ongoing pain, so it means the myocardium at risk, the culprit vessel area is still viable. So pain means viability. So if it's like ST elevation MI, inferior wall, posterior wall, or any equivalent MI, and patient has ongoing pain, so you can thrombolyze.
So one can thrombolyze those kind of scenarios.
Yes.
So what about, sir, suppose today, I got one patient who had an acute LBB, and his age was around 80 years.
Yeah.
So what is your suggestion? Propty came positive.
Yeah, see, earlier we used to, it was an earlier if acute LBB you thrombolyze. Now it's different. If patient has acute LBB and its drop is positive, so it's better to treat him like non-ST elevation MI.
Okay.
Like you can give heparin.
So we go for those
and 80, above 80, the thrombolysis may be counterproductive, like it is contraindicated. So patient, the best, the what makes differences in MI is the time. Okay. If patient presents early,
Right.
So whatever, if you give antiplatelets, even sometimes it will. So what is in MI? What happens? The flow is occluded.
Right.
So what we put all the efforts with the medications or intervention. Here the intervention is missing. So any medication which will help to open the vessel, to dissolve the clot. Right. Acute MI happens with a clot formation, acute clot.
Right.
So the earliest we act, the more likely the clot will dissolve and there will be establishment of the flow. So time is very, very important. So I have seen patients, if they present very early, even if you give them aspirin, it acts like the pain goes away. So you must have experienced this. So that new things like in MI, usually we give aspirin, clopidogrel. Now we should not give clopidogrel if there are other antiplatelets.
Okay.
So clopidogrel we don't give now in acute coronary syndrome. If it is not, if other are like, you should keep Brilinta, Ticagrelor, Prasugrel.
Okay.
So load with aspirin like 300 mg. Chewing is the best because it gets instantly absorbed in the blood. So chewable, or make them chew 300 and 180 mg of Ticagrelor, or if Prasugrel 60 mg. So these are the best. Now clopidogrel is not used in many centers, in advanced centers like.
So it has taken a sort of a backseat kind of a
So
thing.
this is one thing which I want to share in with you, because now here also the health sector is growing. Yes. And I think you should make these medications, tablets available.
Yeah, we'll make it, sir. Previously it was a bit costly. Cost was the factor for
now
us.
There are many companies which very cheaper.
Yeah.
So Prasugrel or Ticagrelor. So you should give this as an acute loading dose. They are very effective.
Right.
Plus aspirin.
Right.
And statins, 80 mg of atorvastatin or 40 mg of rosuvastatin. So these, the main, this is something which is now newer. We don't use clopidogrel.
Right.
And in MI, one thing which I have observed from periphery is that they give subcute enoxaparin or heparin. The best is to give unfractionated heparin and IV.
Okay.
Don't give subcute. And even you don't have unfractionated, if you have Clexane in MI, give it IV. If you don't have to thrombolize. So this is. Now, if like you, I say, there are no two types of MI. One is high risk MI. High risk is like in periphery, you give the first treatment, give loading dose of like aspirin, Ticagrelor, Prasugrel, clopidogrel, whichever, and statins. After that, and you also load with this heparin, IV. Then best is to refer him to higher center. So no need to do further. Yeah, heparin infusion ideally we should give if you keep the patient here. No, because already you have given heparin. It will act for 8 hours. So there is no need. You have given a loading dose of 100 units per kg. So if average patient like 70 kg, you can give 7,000. 60 kg, you can give 6,000 IV. Or you can give Clexane. The best is to give heparin, because when you refer, you have given Clexane. There we use heparin, so it antagonizes. It causes a lot of problems for the cardiologist who is doing urgent angioplasty on him. So best is, I think, whenever give the unfractionated heparin.
So that is in case of high risk patients. That's what you suggest.
Yeah.
What about other MIs, where the patient does not have too much of an.
Yeah. If pain gets settled and you want to manage here, then you want to keep him for a few days, then you can give subcute Clexane for.
Okay.
So that's okay.
So
but
once we referring a patient with a high risk, preferably to give. But
initial dose, I think the sheet should be IV, because it's very effective.
Intervention.
Yeah, unfractionated IV. Because I will tell you, I have very very bad experience. I one day got a patient who had received subcutaneous, the patient enoxaparin, and the patient weight was only 40 kg. She received for 60. So so I thought, no, I should do intervention. His LED was cut off. I was starting. I opened LED. I thought she had received Clexane. I don't need to give, because it's a more dose she had already received. But after when I opened the LED, after 1 minute, I am seeing there is no pressure on my guide. So we always trace the pressure. It means that something happened in the guide. If pressure is not there, first thing is that there must be a thrombus in the guide. So when I opened the catheter, like there is a valve, so I saw there was clot. Then I removed whole guide, was studied with the clot, and his left main there was no flow, nothing. There was a dot in aorta. So it's like patient is going to die. There is no. So luckily I hooked it, and again then I gave 5,000 heparin and sucked the thrombus from left main, and she ultimately survived and everything. So after that I realized this subcutaneous for acute MI, if you have to do intervention, it's not effective. So this is I have, that's why now the best is, if you send for patient is going to center which is trying to do the intervention, the best is give IV heparin or IV first dose. If you want to manage him, give first dose IV, then you can give subcut. So this is the another trick which is very helpful. And we should have in community programs awareness. Like in MI, the time is very important. If patient presents to your center within golden hour, like 1 to 3 hours, even if you load with heparin and many patients, they get it acts equivalent like a thrombolysis. So these are the things. The time is very important, and we should not miss the diagnosis. If patient comes with any acute abdominal pain, chest pain, neck pain, tooth pain, we should always rule out MI. And we should not discharge them. We should observe them over a period of few hours.
So we do it because invariably we get a lot of patients coming with lower abdominal pain, and we found that they had inferior wall MI. And
so these are
invariably we do the serial ECGs in those cases. So one more thing, yesterday we had one patient who had landed, he was referred from Leh to Srinagar and had an acute MI, extensive anterior wall MI, and that patient had VS ulcers. So how do you go ahead in those situations?
See, if ventricular septal, this is a mechanical complication of MI. Like MI, there are complications. One is rhythm related, another is mechanical. So mechanical, there are like septal rupture, free wall rupture, and papillary muscle rupture. So papillary muscle rupture causes acute MR. So patient will be in pulmonary edema, so you have to treat it in cardiogenic shock. And septal rupture, it causes cardiogenic shock. So how we manage is that these carry very high mortality, 90%. So now initially the surgery was the only option, but it has more than around 90% mortality. Nowadays we do echocardiography, and if we find the anatomy is suitable, we can do the device closure. So we should do device closure as soon as we recognize it is septal rupture and it is suitable for device. So immediately we have done previously in the center where I worked in, we have done few cases. If it is not suitable, then surgery is the only option. Otherwise the outcome is very poor. Survival is very, very dismal.
Pericardial, temporal like picture. So in our setting, for instance, if we do an echo and MI comes and we find that there is a temporal like picture, so how should we do it out here in our setting?
So there are now, it's a very tricky condition. If it's there are conditions mimicking MI, like aortic dissection. It can cause pericardial effusion. So then we don't have to drain it because it will be more and more. So best thing is do echo, always a patient of, yes, this is another trick. If patient with acute chest pain comes, we should try to always rule out acute aortic dissection. If you do echo, take a view, try to rotate the probe, tilt the probe to see aorta, ascending aorta, and suprasternal view from this subcostal, and see whether there is some flap. Because I have encountered such few cases where patient came with a effusion and it was treated like an MI. But when it came to me, it was an aortic dissection, rupture into pericardium. So there we should not. And immediately we have, this is a like death sentence. We have to refer the patient to a center where it can be managed. And this is the trick. If it is related to this, any like aortic dissection, then we should not drain it. But if it is related to MI, post-MI, so we should drain it. And if there is no other like acute aortic injury or aortic dissection with a rupturing into the pericardium. So this is how we deal.
So how if electromechanical dissociation and you don't know whether it is MI, since the ECG is going normally, you have tamponade, you have electromechanical dissociation since the myocardium is ruptured. There it becomes tricky, you don't know why this patient is cardiogenic shock.
Yeah, you see, yeah, in MI usually what happens, there is a pseudo aneurysm type, pseudo aneurysm, so we can drain it. See, if it is a free rupture, then patient will not survive, he will die. If patient comes to you, there is pseudo aneurysm formation and it has massive effusion, so you can drain it, otherwise he will die. If it is a free frank rupture, then patient will not, I think, reach to you, and maybe within few minutes he will die.
So what about these coronary artery dissections, and how often have you encountered such patients?
Yeah, it's spontaneous. You mean spontaneous coronary artery dissection?
Dissections, yeah.
Spontaneous, not related to any intervention.
Not related to intervention. Suppose somebody was pregnant, ladies,
Yeah.
things like that.
So this is spontaneous. It's mostly seen in younger people, more in females. So the trick is that if there is flow, we should not do anything. We should leave them on medications like antiplatelet, aspirin, ticagrelor. We should not try to put the stents. If the flow is there and you with flowing and there is no, it's not causing, like it's causing ischemia but not a frank progressive infarct. So best is to treat with heparin, aspirin, ticagrelor or prasugrel. If it is now occluded, so then you have to establish the flow. So this is simple. If it is causing occlusion, open it with the angioplasty. If there is flow, so leave it. It will heal within 4 to 6 weeks. So this is how we go.
What we encounter, almost every doctor encounters certain scenarios in a district hospital. You have an ST-elevation, right? Say entry ward. You go for thrombolysis. Save a real good time. But it's a failed thrombolysis. We have given aspirin, we have given beta blockers as well as ACE inhibitors. If morphine we don't have, so at most we can give sort of natural medicine and all. But pain persists. You go for thrombolysis other agent, it doesn't. We have to shift it for a plastic now. How to proceed till the patient reaches Srinagar? We cannot send them in that agony also. Then events in the we face.
Yes, see, this is very unfortunate because we should have these things like intervention. Because if the thrombolysis fails, we have only these options. You see, we have to address the pathophysiology, the clot. So the best thing is we have is thrombolytic agent.
Put on some GP2B inhibitor.
Yes, the trials they have shown a negative results. It causes more complications. The trials, it's known as facilitated thrombolysis. It has not been shown. So only thing is you can give heparin infusion like that, and thank you.
Thank you so much, sir, for such a fruitful interactive session. The feedbacks that you have told for colleagues can be life-saving at sometimes for our co-patients. Now I'd like to invite a senior consultant gastroenterology, Dr. Adil Ashraf, to give a talk on AI in GI endoscopy. Because modern times are the times of artificial intelligence. Dr. Adil Ashraf has a fellowship in advanced GI endoscopy from Asia Hospital, Hyderabad, and he has also a fellowship in full thickness resection of cancers from Ovesco, Germany. Dr. Adil Ashraf will give a talk on AI in GI endoscopy.
So, Assalamualaikum, an August gathering. It's good to be back here, within a period of 2 months, I guess. So today I thought to talk about a topic which is a bit different from the routine. It's interesting if we like to make it interesting. So we'll be talking about artificial intelligence in GI endoscopy. So when we talk of artificial intelligence, is it new? No, it's not. Artificial intelligence has been in vogue. Actually, the concept of artificial intelligence came in Second World War. So there were German soldiers were sending across messages to their encrypted messages to their soldiers, and the enemy, they had to face a lot of damage over many months and many years. Then they formed a code that there was some pattern in those encrypted messages which they were sending across, and that was the basis of this guy who's called as Alan Turing, the father of the modern computers, and which formed the basis of the artificial intelligence. So why, when we talk about the modern artificial intelligence, it actually came into full force in, Desert Storm, the Kuwait War. So when it has been in vogue from in 1990s, and in the most of the cities now, the traffic and all that is AI based. But somehow in healthcare and in medicine, it's still, there are roadblocks. It's not finding the pace where it should have been when it's in use in other things. The reason for this is that, when there is a talk of traffic, we boast about that the traffic of our city is AI manned. It's all controlled by AI and we are modern. But when we start to talk about AI, so the neurologist is sting here, it goes into the head that AI is going to probably replace me, because there is a head-to-head collision of AI with the human brain. That's why there has been a lag of, some decades application of artificial intelligence into the endoscopy in modern medicine. But then this was the wrong question which was actually in place for so many years. That whether it's a tussle between the human brain or it's a fight between the human and the machine. So they say that we lost around 3 to 4 decades in this question, and the actual question should have been how can we make the better medicine based on the collaboration with AI. So to make it simple, I won't go, it's when we start about it, it's very, very difficult, all the algorithms and all that. What actually this AI is, we have all the cups and, bottles and different this glasses here. So the AI basic model, it starts like that. There will be random pictures of everything which is round and tall like this. And then it will be refined to the extent, feeding the computer with lakhs of pictures. Then at the end, it forms a model where it will differentiate that this is a glass, this is, this is a jar, this is a cup, and all that, so on and so forth. So, is artificial intelligence in medicine? It's not a future. It's already there, and it's in use in a lot of, these specialties. When we talk about the artificial intelligence, the application and how does it interfere with day-to-day activities. I don't know whether I should use the word fortunate, but somehow we witnessed the latest, a 4-day war between India and Pakistan, the Operation Sindoor. So they say that, analysts say that the amount of man force used, the amount of brain behind all this, it was actually at par with the 65 war. The 65 war, it was for 17 days, and this 25, sorry, it was for 4 days only, because both of these wars, they were fought in a different domain. That was a physical war, all the tanks and the army soldiers marching and all that, and this time it was nothing. It was going on in rooms and all that, controlled by all machines and all that. And we boast about it because it was all, the countries, they say that we have been doing, the Israel bombarding those pagers, all AI driven. But somehow we are lacking in this. And a very important thing, I won't go into the theory. I'll be just talking extempore regarding some things. I guess most of us must have used ChatGTP. So once ChatGTP was started, if you must have written, while making your thesis and all that, kindly give me a latest paper on some topic in 2024. But that would say the data with me is only till 2018 or 19 something. I'm not sure about the date. There was a limit put on to that, because that was a test. ChatGTP, it was being tested and all that. Because the biggest fear with all these AI models is the self-replication. That what if these models or this artificial intelligence starts to self-replicate? Self-replication means that it starts getting intelligence on its own. The earlier models where you feed the data with lakhs and lakhs of images, data and all that, then it makes a model and then gives a result. But what if this model starts gathering all the information by itself from all the data and then gives a model of it? That's how it replaces. And it happened in 2025 actually, when there was an AI model by Alibaba and the Chinese DeepSeek. So there was a loss of around, if I am correct about the data, it was some $23 billion in 3 days, which was lost because of that thing. So when we talk about the gastroenterology, so how does it simplify? This is all theory. I won't go into this. It will make the evening boring, and there is a time constraint as well. So this is the basis of all models. There is a machine learning and then there is a deep learning. Machine learning is that you feed the computer with lot of data. Then deep learning is, it forms a convoluted network like the gray matter of the brain. It forms those deeper networks where you ask the computer to give me an information. It uses all those convoluted networks and then flashes it. So this is the basis of all these. And probably in next 2 to 3 years, we'll be having all data which will actually be self-replicating, and where does it land, we don't know. So where have we used it and where are we right now in this? We know the most common cause of malignancy when we talk of gastrointestinal malignancy, which is actually prevented, is colonic malignancies, and they start from colonic polyps. Small polyp, neglected, not seen, colonoscopy not done, colonoscopy available but biopsy not done, pathologist not expert, biopsy not taken from proper areas, all leads to a lot of errors. Okay, so then there were different, it all starts from, actually everything starts from the Chinese region only. So it all started from those where, millions and millions of these images of colonic polyps, they were fed to the computers. First a machine learning was done, then a deep learning was done, and then, it forms a module where you do a colonoscopy, you flash on the polyp and it picks itself whether it's a malignant or non-malignant polyp. I was fortunate enough to be part of one of the international group working at my previous workplace. So this was one of the studies when Olympus used a software. It is called as an EndoBrain. So we used it in Hyderabad. So, and how does it show? This machine it's at your back. You don't get to see this machine. So you do a colonoscopy, you see a polyp, you freeze it, and you send this picture. It's instant. It's that time only. You just click a button on your colonoscope. It sends into that computer, the mega computer, and the mega computer it presents just in a flash of second. It depicts the result as this, whether it's a neoplastic or whether this is a non-neoplastic. Then there are studies, then we study it, like we take the biopsy and then go back and again look whether the machine was right or wrong. So these are the different type of polyps, on the upper hand, a non-neoplastic polyp. And what does it do actually? It has a relevance. lot of money saved. You don't take in a biopsy. The concept of green endoscopy and green medicine now, limiting all these carbon emissions and all the waste matter and all that. So again, when we talk in esophagus, the same pattern. You take and then what happens with actually is that when we were doing that, that's an ideas group from Poland and Korea. So when we started it, at the initial module, it was picking stool matter and polyp. It was flashing on both. So in the first module, it was picking stool also as a polyp. Then we did, some 5,000 and all that colonoscopies. All this data was again transferred to Korea and all that. Then the refurbished one was that it would distinguish between the floating stool particle and the polyp. Then the problem was the stool which was stuck to the colon. It was again picking that as a polyp. But then again, you go on changing, you go on working with that, and that's how these artificial intelligence finds its way. Then uses, it has been tremendous use in GI endoscopy, in colonic polyps, in I'll show, this is one of the polyp, 10 years back. Dr. Isaac is here, he would take this patient for hemicolectomy and all that. Now you use an artificial intelligence, you see what are the type of vessels, what is the musculature and all that, the mucosal pattern. You somehow feel that the depth with endoscopic ultrasound, it's not that deep. You go for the resection, endoscopically resected. This becomes the base, that whitish part is the muscle, it is preserved. You remove it and the patient is saved from a major surgery. Then see, this is a mass, pancreatic mass, the roundish thing in a chronic pancreatitis, and they have these heterogeneous masses, and all of the tumor is not malignant actually. There will be areas within this tumor which will be malignant, there will be area within the tumor which will be non-malignant, and there will be foci of dysplasia only. So endoscopic ultrasound guided biopsy, if we do it from an area which is not malignant, it has a lot of impact on the patient. So then there is a concept of artificial intelligence in US that's called as an, it's encrypted in that system. So it shows the areas which has very high chances of being malignant based on the elasticity of the tissue. You take the directed biopsy and the job is done. So the final question, will AI replace doctors? Surely not, but a doctor knowing AI will surely replace another doctor. Thank you.
Dr. Adil, this was part of an intervention only. What about virtual endoscopy? Has any progress been made in virtual endoscopy?
Sir,
CT slices and
yes. So when we talk of colonoscopy, especially in elderly people who are very sick, friable and all that, there has been a lot of study done on CT colograph, and then its correlation with the normal endoscopy. But to be frank enough, till now there has not been any module which has actually replaced endoscopy. Now the concept of magnetic driven endoscopies or magnetic driven capsules which are incorporated, AI incorporated, we do capsule endoscopy, but you cannot control the movement. Sometimes the camera will be back facing and there will be a lesion or a tumor on the other side of the wall. So now AI with magnetic driven those sensors, it uses those sensors where you can manipulate the movement of this. And again, in radiology, there must be some radiologists also here. It's again, it's very surprising when I joined Hyderabad, there's a lot of emphasis there on data. Collect data, everything. Even if you don't go home, but you have to give that data. And then it was like there is a term called as acute on chronic liver failure, very rampant in India. Dr. Sareen from ILBS, all PGI, SGPGI, a lot of work done. Then there was a collaboration with Dr. Rajiv Jalam's group in US and ILBS in Hyderabad. They were paying $2,500 per patient only for the data. You know, the first SMHS का वो sheet उसके लिए $2,500 मिलते थे, and now it's that algorithm coming AI driven of ACLF. So it's everywhere, you know, sir. The CTs, you know, you give lakhs and lakhs of images that chronic pancreatitis में ट्यूमर जो है क्या ये एडेनोकार्सिनोमा हो सकता है, what are the possibilities, because of, you know, lakhs of images being sent कि chronic pancreatitis में मास कैसा होगा, एडेनोकार्सिनोमा में मास कैसा होगा, likewise, you know, chest mass is malignancy related and all that. And to be frank enough, sir, you know, it's not something that it needs to be done at high-tech centers only. You know, AI is something after 5 years, 6 years, we actually are all using AI, but just that we have lagged application of this in the modern medicine. That's where we lag. It's a matter of time that it will be in vogue and in use everywhere actually.
Dr. Magnificent presentation, but what are the risks of over reliance on artificial intelligence in endoscopy?
Actually, the thing is, in our setup, yes, it does. Maybe it may not be of use, but you know, when it has been used in areas, you know, for example, it started in Japan. Japan has an endoscopic screening program. It's not like us, sir. We do endoscopy when we have a stage 4 cancer. So they do endoscopy starting from 20 years of age. All these endoscopy driven these things, this mucosal pattern, vasculature pattern, it has all come from Japanese actually. So the time spent on endoscopy, they do an endoscopy for around 1.5 hours. They read each and every area, what is the muscular pattern, you know. Fortunately, I have worked with some of them. They don't need a biopsy, they don't do biopsies. They will tell you just doing an endoscopy, it's same endoscope which we use. They'll tell you, no, this is H. pylori, this area is dysplastic, this area is. So when their mind is trained like that, then you incorporate that into a machine, it's going to have a lot of impact. Maybe yes, into a clinical practice, you know, a day-to-day practice maybe might not find relevance right now in our part of the setup. But yes, there are areas, and I think, you know, some of the colleagues going into this, some of the younger generation going into this, that should be.
I have one last question. Sometimes we do endoscopy out here, and we take a biopsy from the antrum most of the time, and we get metaplasia, dysplasia at times. So how should we go ahead in such patients?
Absolutely, sir. Sir, metaplasia, you know, abnormal mucosa, normal mucosa being replaced by an abnormal mucosa. So the most common cause of metaplasia in our region, in subcontinent, is actually H. pylori related. So there is now a consensus paper that even if H. pylori is absent in the biopsy, but you should treat for H. pylori in high endemic zones and all that. And then we have to repeat an endoscopy after 3 months. In most of the times, this metaplasia will go down. If metaplasia is still present, then we have to actually go for a 6-area biopsy, you know, Sydney protocol and all that. You take it from antrum, you take it from incisura, you take it from anterior wall, posterior wall, and then proximal body. You take biopsies, label them differently, and send them separately. And, you know, metaplasia is not something which is going to convert into a, you know, this malignancy. It follows a sequence in most of the times, you know, metaplasia, dysplasia, then that atrophic gastritis, and then progressing into that. But metaplasia in our setting, everybody, even if H. pylori is not present right that time in the tissue, they have to be treated for this. And then smoking, some food. Yes, sir.
So should we repeat the endoscopy within 1 year or 2 years?
Sir, for metaplasia, if we have treated, we have to document the response after 3 months.
Okay.
After 3, if patient had H. pylori positive, then no need of repeating an endoscopy. Just a breath test or a stool examination, that should suffice. And then repeating after a year.
Okay. So we should repeat?
Yes, endoscopy we should repeat. Yes, sir. Yes, sir.
Giving us a tour of future in healthcare, riding on the back of artificial intelligence. On the question of whether artificial intelligence will replace a doctor, I'll just make a small comment. It will replace doctor only if the artificial intelligence is used on the level of a patient. If a patient starts to use artificial intelligence instead of a doctor, then it can replace a doctor. On this, I'll give an example of drawback of using artificial intelligence by a patient. There was one case in our India only. A patient was having a throat irritation or something like that, some throat symptoms. He put all his symptoms in ChatGPT, and ChatGPT suggested nothing to be worried about, just take treatment for LPR. He took treatment for LPR for 4 months. At 4 months, he went to the doctor and stage 4 throat cancer was detected. So there is no need to be frightened of artificial intelligence. Artificial intelligence, if used by expert doctors as a tool, it can be a guide, it can be a tool in our hands. So now I'd like to, we will hear a talk on a very prevalent symptom, which is very prevalent in our region, headache. Headache is very prevalent in Kargil. Almost everybody is suffering from headache, chronic headache in Kargil. There is special kind of headache in Kargil. I like you to make a comment on it. People say we have a headgear kind of headache. People say whenever we remove our cap, I have headache. So people here wear even woolen head caps even in summer months. They say when I remove my headgear or head cap, I'll have a headache. So as an ENT, I have evaluated them for sinusitis, but they don't have sinusitis. So I'd like to make you a comment on that kind of headache also. So now I'd like to invite Dr. Adnan Firdoz Raina, Senior Consultant Neurology, Paras Hospital, Srinagar. He is a young neurologist with credentials like DM Neurology, MRCP Neurology, and he is a certified member of European Board of Neurology. He'll give a talk on what is new in headache. Dr. Adnan Firdoz Raina.
Thank you, sir. Thank you, sir, for your kind introduction. I'm happy to be here, first time in my life in Kargil, and I would like to first comment that those doctors who are working here selflessly and tirelessly, a salute to them for their dedication and service. So I'll be talking about what is new in headache. As you all know, migraine, you would have treated migraines here. Many of physician friends, some senior, some of my colleagues who have worked with me in SKIMS. So migraine has revolutionized over a period of 5 years, and now all therapies are based on CGRP, which is a calcitonin gene-related peptide, which is actually a peptide which is being held responsible for migraine. And there are many devices which have come. Neuromodulation is in vogue now. Usually people wear devices and they treat migraines with devices now. And also there are options of Botox. So you'll be surprised to know that migraine is as common, more common than diabetes. Diabetes is being talked about all over the world, but migraine is more common. But obviously diabetes has a lot of complications. Migraine only affects the person and his daily activities of life. It incapacitates people who have migraine. And it leads to, there is a lot of treatment gap with migraine. It is not being recognized as a disorder, and it's being treated as simply as a headache, and ultimately it goes into chronic phases and then becomes refractory to treatments. So the root cause of migraine currently, the theory is that there is a cortical spreading depression in the brain. Because of that, there is release of calcitonin gene related peptide, and that leads to migraine and migraine attacks. And now the drugs which have come, they are both monoclonal antibodies and receptor blockers. They are called monoclonal antibodies and GPANTs. In them, there are different drugs like rimegepant, urogepant, atogepant. These are the oral drugs. Then you have some antibodies where you give monthly, or even you give quarterly, where you give 3 monthly a dose and patient is headache free, like galcanezumab. So, are there any drugs available right now in this new era? So you'll be happy to know that now Pfizer has recently launched one of the GPANTs in India, which is known as rimegepant, which acts as an oral as well as preventive therapy. And there are only antibodies which are present in India, available in India, which is irinumab therapy. And we have in our hospital, we have already started giving irinumab therapy, and we have 24 patients in our clinic which have been given Ironimab therapy, and over the period of last 1.5 years, we have given it to 24 patients, and out of that only 23 patients after 6 months they have no attacks. They are only taking abortive treatment. There is no other prophylactic treatment which is being given to them. So there are also nasal sprays which have come now in form of Zavegepant, which is and now newer discovery which has recently been launched in New England Journal of Medicine, which are PCAPs, which is pituitary adenyl cyclase inhibitors, which are being used where they say that some patients who do not respond to CGRP inhibitors, they have this pathway which is being mediated through the pituitary gland, which leads to the headache. And they have these antibodies have been trialed, and they have also shown great results. What is neuromodulation? Neuromodulation is a remote device where a device is being worn by the patient, and the electrical stimulus prevents that cortical spreading depression, and it prevents the acute attack. It acts as an abortive therapy. So it has been cleared, and the device which is currently available in India, which it is known as Nervio, and it is a wearable device. It comes at a cost of around 12,000 rupees, and you can use it for 18 sessions. Each session lasts for 45 minutes. The other preventive therapy, prophylactic therapy, which is in currently being used is for chronic migraine, is Botox. Botox is already being used for multiple aesthetic purposes, but it is also effective in onabotulinum toxin is effective in chronic migraine, where it is being given. It has been approved by FDA in 2010. And a targeted administration is being done around the head, and that leads to a prophylactic treatment for chronic migraine. It has a response rate of 50%, and it reduces the number of days of having chronic migraine, and it has patient satisfaction of approximately 85%. So we have to integrate these treatments in our practice. Now, what we have done actually, what studies have done actually, they have used abortive treatments, and then they have used prophylactic treatments for 2 agents. Once they have treated the patient with 2 agents, after that they have switched to these GPANTs. But however, here in India they are a bit costly right now. In our center we are using it after using for 4 agents. We use 4 agents first. After using 4 agents, once we see that there is no response, we give patients an option that this is a treatment which you can avail, and you have to give it at least for 6 months and see the response. And usually these are chronic refractory migraine patients who are enrolled right now in our study, and who have taken the treatment. There is a lot of cost involved in this right now, but in near future, 4-5 years down the line, we see that Indian companies will come with these drugs, and it will completely revolutionize the treatment of headache. So we have wearable technology, we have CGRP, GPANTs, PCAP antagonists, we have Botox. The device is wearable, where you wear the device and you use it through your phone. Thank you. I just wanted to be brief.
Sir, previously, sir, we had this thing now. We were told that it is a vasospasm followed by the vasodilatation, which was headache. Does it still stand, or it has been?
It doesn't stand true, sir. If you see the basic pathophysiology of migraine, if it was only vasospasm and vasodilatation, then propranolol would not have been the initial drug for that. Okay. So if it would have been vasospasm, so we would not give beta blockers to do that. So obviously the current pathophysiology, which is of CGRP antagonists, CGRP pathology of corticospastic depression, this makes more sense where we have used these drugs and they are completely eliminating people even of migraine attacks.
Okay. So what about using this prophylaxis? When should we use it, and how frequent the headache should be there, and then we should go for this prophylactic treatments?
For headache, initially, you have to first see that it is always a stratified care. Although in our setting we don't follow that, but we have to actually tell the patient whether you want abortive treatment or you want prophylactic treatment. Because obviously in guidelines there is no prophylaxis less than 6 months. We always do not follow 6 months, and nor do our patients follow. They just after taking a strip of propranolol or topiramate or something, after that they say obviously now कुछ फर्क नहीं होगी तो अब क्या आपने दवाई दी थी, तो obviously they don't understand it that it has to be very prolonged. So we have to initially tell the patients that if you want abortive treatment, then give them abortive treatment. But however, if the attacks are very frequent, suppose there are more than 4 attacks in a week, and patient has, even if he has 1 or 2 attacks and they are very disabling, the patient is not able to do his daily activities of life, at that time you have to start prophylaxis with a single agent based on the other comorbidities which you think, whether patient has hypertension or depression or comorbid depression or he has obesity. All those things have to be taken care of, and with that you have to start the prophylactic agent.
So which drug you use frequently as a prophylaxis, sir?
We use usually propranolol, amitriptyline. This is conventional with migraine initially, because using divalprox gives a lot of problems, and migraine is prevalent in females. So if you use more of divalprox, it creates more problems with females. And topiramate has in itself, once you try to give it for a long period of time, it has all adverse effects. That's why these drugs have come, and they have less of side effects, and this, the one which has come in oral agent rimegepant, it is where you take the drug, it gives you an abortive treatment, and it then gives you a prophylactic period also. So it acts, suppose you take the drug and 4-5 days you will not have an attack. So it acts both ways, abortive as well as preventive.
So I saw one patient with a complicated migraine. Patient used to come with headache and then had a hemiparesis. The moment his headache used to go off with propranolol only, and his hemiparesis would disappear. So how often?
This is a very rare condition which is called hemiplegic migraine, where you have to do mutations, which is SCA1, 2A mutation. It is usually, sometimes it is the single patient, or sometimes it runs in the family, which is known as familial hemiplegic migraine. And first initially you have to rule out strokes in them. Once they come frequently, then you have to obviously label this condition as familial hemiplegic migraine.
Thank you. Thank you.
Thank you.
Thank you so much, sir, for such a short, crisp and insightful talk. For the time being, we will stay in the brain only. For the next talk, I'd like to invite Dr. Rahil Rafiq. He's a consultant neurosurgeon in Paras Hospital. He's trained at AIMS New Delhi, and he was ex-faculty in AIMS Jammu before moving to Paras Hospital. So he'll give a talk on a neurosurgery topic.
Assalamualaikum. मेरा नाम डॉक्टर राहिल है. I am an AIMS trained neurosurgeon, and I'm currently working as consultant neurosurgery in Paras, Srinagar. Before I begin, I would like to thank everybody for taking out time and coming to this location and participating in this discussion oblique CME in a very brilliant way. And I would also like to thank for welcoming us, because I have been first time here. I really like the people, I really like the culture here, I really appreciate the cultural values and the social work that your organizations are doing here. They're really, really commendable.
So you are praising beauty of mountains.
Definitely, sir. So before I begin, I would like to introduce our team at Paras Neurosurgery. So our team comprises of a mixture of experience and youth. So our team is led by Dr. Altaf Ramzan, who is known in Kashmir Valley quite well. And then there are two workhorses. One is my colleague, friend, senior, Dr. Irfan, and then there is me. I've been trained in AIIMS, that as I already mentioned, and then I worked in Delhi NCR, and then I was faculty in AIIMS Jammu also, and then I came to Paras Srinagar. So before I proceed further, I would actually take a brief moment to explain what is our goal and what is our approach to neurosurgery at Paras Srinagar. So I am a recent joining there. I have joined Paras somewhere around 6 months back, and since the beginning of my journey in Paras, we have always focused on making complex a routine thing in neurosurgery there. Our goal is not to generate too much amounts of volume, but our goal is to definitely take care of the complex things which would definitely require referrals out of state. So our goal is very simple, to make complex things routine at Paras. And today my job here is actually to generate some amount of belief that those complex procedures are possible at Paras, are possible in our vicinity. So my approach to generating that belief is to showcase some amount of work. We are dealing with tumors right from the top of skull up to the sacrum. It includes complex brain tumors, it includes deep-seated tumors, it includes craniovertebral junction anomalies, it includes cervical spine, dorsal spine, includes spinal tumors, it includes minimally invasive spinal surgeries, it includes everything, okay? So there were too many cases to actually highlight that we have done in the past 6 months, but I have chosen these 3 cases to actually highlight our work. One is navigation and fluorescein guided tumor surgeries in brain. Second is craniovertebral junction anomaly surgeries. And third is minimally invasive spinal surgeries. I will like to go very brief about them, if possible, probably. So what is navigation surgery? Navigation is nothing but a tool. It makes our life really easy, because it gives us guidance, real-time guidance inside OT, by which we can pinpoint our instrument location inside somebody's skull, inside somebody's brain, and it is very accurate. When I say very accurate, it is sub-millimetric accurate. It is accurate up to 0.1 millimeter of accuracy, okay? So how do we do it? We basically take a CT or an MRI of a patient. We load that CT. This is the medical image that this is the first step, scanning the patient. These are very thin slices, 1 millimeter thin slices. Then we prepare it into a machine, which is basically a neuronavigation suite. We have one at Paras. Then we register the patient's anatomy with the medical imaging. So basically there are 2 infrared cameras with the navigation suite. So it takes photos of the patient while we are registering the skull anatomy, the topography of the patient into the machine. By that, what it does is basically it creates a 3D model inside the OR, and then it calibrates our instruments, and we can use them during surgery for many things, which I will highlight now. So this is one of the things is neuronavigation guided biopsy. This I will skip. I will just show you the main part. This is let me just freeze here. So this is a patient who was 46-year-old male patient. I will reveal the biopsy later because it was one of the rarest cases that we have actually faced. So this is a contrast enhancing lesion in right parietal lobe, and it has central necrosis, and there was gyral expansion. It had been biopsied prior to reaching our center, so the biopsy was low-grade glioma, but we were thinking that it is probably a high-grade glioma. So we did a pre-op CT, a pre-op MRI, and then we proceeded for navigation and fluorescein guided tumor decompression. So localizing tumor under neuronavigation. So what we do basically before starting our incision, we can localize the tumor within the grasp of our hand, and that actually cuts short the incision, that cuts short the craniotomy, that cuts short the blood loss. So this is where we use fluorescein. So we have the fluorescein, sodium fluorescein, that most ophthalmologists use. So we give it half an hour before proceeding for surgery. The uptake of dye in tumor is more than the uptake of dye in the brain, because of which the tumor shines brightly under the blue light. So there, okay, so this was the part where we were basically taking out the tumor. Then we were checking for the extent of resection using navigation. That is the beauty of navigation. Intraoperatively, you can check for the extent of resection. You can be sure that you have taken more than 90-95% of the tumor from the patient's skull. So then we again switched back to the fluorescein, and we were taking out all that shiny part, which is the fluorescein uptaken part from the tumor. Once we were done, then we were checking for the margins, whether we have cleared all those contrast enhancing margins that were present in the pre-op contrast MRI. And then we did a post-op scan. The patient had pre-operatively hemianopia. Post-operatively he had subjective improvement. He is currently under follow-up, though his disease has progressed, and the biopsy came out to be histiocytic inflammation. It was not glioma either, and we have had multiple tumor board meets on it, and we are still wondering what kind of histiocytic lesion it is. So far our differential is actually Rosai-Dorfman disease, because its ISC came out to be positive, and the rarity of this lesion being intraparenchymal is very, very rare. Roughly around 49 to 50 cases in all of the world has been reported about it. So that was one, we accidentally stumbled on this rare lesion, and we are currently treating him with corticosteroids. There are other drugs also which are currently in market. So navigation basically makes our life easy, because it localizes the tumor, it can pinpoint our instruments, it can reduce the blood loss, it can reduce the length of the surgery, it can also predict the extent of resection right there on the OT table. Okay, so that was one. Second is craniovertebral junction anomalies. These actually, they are difficult, let's be honest. They are difficult. There is no fun about saying that, okay, everybody does CVG. Nobody does it actually, because they are difficult. Why are they difficult? Because in a very small space, all the critical structures are packed. Within 1 to 1.5 centimeters, spinal cord is there. There are two vertebrals which are roughly around 2 to 3 millimeters away from the lateral masses, and you have to put screws into those lateral masses, which are roughly 6 to 8 millimeters wide, and you have to put a screw of 2.5 to 3 millimeters within those 6 millimeters. So that is why it is difficult. And the part that the dissection itself actually makes the bleeding is there are a lot of bleeding. Then there is C2 ganglion which has to be dissected to expose those C1, C2 joints. That is the difficult part in it. The dissection itself takes 2 hours, sometimes 2 to 3 hours to basically dissect out those joints. And then too much of manipulation, the patient becomes quadriplegic. The patient goes onto the vent. Vertebral artery injury, the patient goes into posterior cerebral stroke. The patient lands. Sorry, can you hear me? Yeah, sorry. Yeah, so can you hear me? Yeah. So if the vertebral artery is injured, patient goes into posterior cerebral stroke, lands into coma, goes onto ventilator, eventually dies. Very rarely they make out of those kind of things. So the margin of error is really, there is no margin of error there. If we err, the patient loses life or becomes quadriplegic or becomes hemiplegic. That is why it is difficult, and that is what makes it challenging. So fortunately in these 6 months we have operated 3 patients out of in PARS, and we have done one we have done C1 C2 fusion, one we have done DCR, which is decompression, compression, distraction, compression, extraction, extension and reduction technique, which is basically done to reduce the basilar invagination in patients. And third, we have done type 3 odontite fracture, in which we had to do C1 C2 fusion again. So this is a case of a 35-year-old gentleman who had tried all places in Kashmir, had struggled for 6 months to find the right place to get operated, and he had, if you could appreciate, this is what he had. He had an atlanto-axial dislocation. The C1 vertebra had translated anterior to C2 vertebra, and there was a fracture in C2 vertebra also. This was his MRI, and bilateral angios was normal. They were arching lateral to the C1 C2 joint, and they were arching over the C1 arch, which is the normal anatomy of a vertebral artery. This is a very small clip of what we do inside OT, how we do it. So basically, the dissection is actually carried out within the microscopic view. It cannot be done in naked eye. We proceed to paraspinal muscles with naked eye vision, but once we are done with the laminal dissection, we proceed with microscope, because all those critical structures are very tight packed, so we have to do it under microscope. This is where we do the microscopic dissection. And this is C1 C2 joint being exposed, and the ganglion being pushed medially. And this is, we do instrumentation under the C-arm guidance. This is my colleague Dr. Irfan performing C2 screws during this surgery. So this is the guidance screws. So this is the pre-op, and this is the post-op. This is how the post-op basically looks like. These are C1 screws in the lateral mass reaching up to the anterior tubercle process, and these are lateral mass screws in the C2, basically past screws in C2, and these are C1 C2 spacers that we had put. So, well, this is some very small intra-op clip of C1 C2 fixation. That is when we proceed with this dissection. These are very. This is basically microscopic view of all that dissection that I was discussing earlier. This is C1 arch being taken out. This is C1 C2 joint being prepared for spacer insertion. So everything is hunky-dunky till surgery goes good. But nothing is good if the post-op is not good. So the post-op is, this is the post-op day one of that patient. Fortunately, touch wood, we have not had complications in CVJ, though this is a very complex matter to actually deal with. But all three patients have gone well so far. So, and especially with C1 C2 is okay, but DCR is more complex, because you have to basically extract that the dents which has gone inside the foramen magnum, and it leads to distraction injuries in cervicomedullary junction. Fortunately, if the case selection is right, if the technique is right, and if the surgery is done slowly, these things are done. These things are possible, and patients do have good outcomes. So that was the second part. Now comes the third part. This is very close to my heart. Minimally invasive spinal surgeries. So before I proceed further, I would like to explain what minimally how minimally invasive spinal surgery is different from conventional or open spinal surgeries. So basically, conventional open spinal surgery, as we know, involves dissection of paraspinal muscles, involves dissection of the spinous process, the lamina and the facet joints. We expose them first, and then only we proceed for the further steps, which includes laminotomy, taking out the ligament flavum, then retracting the thecal sac, and then taking out discectomies or doing fusions. Okay, this is what conventional or open spinal surgery is about. How is minimally invasive different from it? So basically, there is a principle that we don't dissect the muscle. That is the principle. That is what basically minimally invasive spinal surgery is. So how do we approach it? We basically use a dilator. We go underneath the muscle and dissect the small part of paraspinal muscle which is attached to the lamina, and then we work all the surgery. We work beneath the muscular layer, which is roughly around, usually it is roughly around 4 to 5 centimeters of muscle, but it can be sometimes 6 to 7 centimeters, which makes the surgery sometimes difficult. But if it is 4 to 5 centimeters, it is usually manageable. So we work all the surgery is done beneath the muscle layer. Once the tube is taken out, the muscles repose back. We don't expose any facet joints. We don't expose any the contralateral lamina. We do everything within that tube. It can be done both microscopically. It can be done endoscopically. The difference is microscope offers 3D vision, endoscope offers 2D vision. That is the basic difference. And there are other advantages, disadvantages. It is still debatable which is better, but whoever is compatible with one of the approaches or both of the approaches is okay. Okay. So does it really make difference? Yes, it does. It reduces post-operative pain, requires less amount of analgesia, smaller surgical scar, roughly around 1 to 1.5 centimeters, less tissue disruption, lower infection rates, significantly less blood loss, hardly 10-15 ml, less or no post-operative instability or weakness because the facet joints are not exposed, are not drilled. early ambulation, faster recovery, shorter hospital stay. All of them are basically acute advantages, but there is one major advantage, which is low risk of future adjacent segment disease or failed back syndromes. This is in the long term. This is where basically minimally invasive spinal surgery is picking up, because people believe now that once you have not dissected those facet joints, you are not exposing those facet joints to degeneration. You are not exposing the patient to further spinal degeneration. So basically that is why these minimally invasive spinal surgeries are picking up. So this is literature, I would just skip it. There is a lot of literature to actually support. Older surgeons would refute that this is just jargon. I would say, though in the long run, I would say the pain outcomes, the hospital stay, they may not matter, but adjacent segment disease does matter. If you operate at one level and say like 6 years, 10 years later, a young patient you have operated, and 10 years later he presents with spinal degenerative disease at another level, then it's not justified to that patient. So that is where I actually believe minimally invasive approach should be taken up. So this is one of those patients. He had a large L4-5 disc. So we have done unilateral laminotomy, gone onto the other side by doing bilateral decompression through undercutting the other lamina and taking out both the lamina, both sides of ligamentum flavum, and then decompressing all the bilateral nerve roots. So I will just fast forward it. I don't want to bore you guys with this. So these are the steps of minimally invasive spinal surgery. So we first dock a tube. After docking the tube, we expose the lamina, identify the spinolaminar junction. Then we dissect that. We do a small laminotomy, which is roughly the size of my fingernail. And once we are done with that, basically I will just show you some part, which is basically this. This is the thecal sac. Thecal sac, we are trying to decompress the contralateral nerve root. So we approach it from one side. We decompress the other side of nerve root first. Then we come to the ipsilateral side and decompress this side of nerve root also. This is the contralateral nerve root which we are trying to decompress all the way up to the foramen. Then we will go on to the ipsilateral side and decompress this also. As I said, all these surgeries are hunky-dunky. But if the post-op is not good, nothing is good. So I will just show you this is one of the patients I have done roughly 7-8 months back. So this is the pre-op video. This is after 4 hours. This is after 4 hours. Sorry?
Patient is from KARGIL.
No, this is not from KARGIL. No, this is not from KARGIL. No. She may look like she is from Shipyard. She is still under follow-up with me. She is doing good. She had gotten 2-level decompression done via 2 centimeter incision. 4, 5 and 5S1 levels had been done. And okay.
The backdrop doesn't look like Paras.
Yeah. I told you this is 7-8 months before I joined Paras. I'm not saying this is from Paras, but these are minimally invasive spinal surgeries that I have done. I can show you one more from here. See, this is one of the severe canals that I have decompressed. You can appreciate that hardly any nerve roots are visible. Okay, so this is our pre-op and post-op videos. And this change you can bring within 4 hours of surgery. It's possible because post-operatively you have not dissected the muscle. You can make the patient stand there and then only. And I usually do it under GA. So once they recover from anesthesia, they are able to walk. I don't do it in spinal. Sometimes if the patient is not fit for GA, then we can do it in local also, as well as in GA. As well as in spinal anesthesia. That is anesthesia parts. Okay. So my take on this is basically spinal surgeries are safe and minimally invasive spinal surgeries are even safer.
Thank you.
Anik.
For giving us a pictorial description and a video insight of the quality work, international quality work that is going on in Paras Hospital. Now we are not much far from the dinner. Only 2 talks are left. So only one and a short description. So now I'd like to invite our Dr. Ishaq Nabi. He's a consultant general surgery and laparoscopic surgery at Paras Hospital, Srinagar. He's given a talk on laparoscopic sigmoid resection. Dr. Ishaq Nabi.
Great hospitality, and I have just noticed that the people of Kargil, I have the most gentle people I have seen till now in my life. So, and thanks to all these doctors who are doing great service to such far-flung areas.
Across many continents.
Yeah. So, I'm Dr. Ishaq Nabi. I'm working as a consultant general laparoscopy and colorectal surgery in Paras Hospital. I am a member of these few organizations like Royal College, Medical Council, Association of Minimal Access Surgeons of India. And so today I will talk about laparoscopic sigmoid resection. So as a laparoscopic surgeon, we usually advocate minimal access surgeries because it has so much benefits over the classical open surgeries, like faster recovery, it's safe, better vision, less complications, and quick recovery to the work. So we had this 16-year-old girl who was having recurrent attacks of constipation and obstipation, and before presenting to our hospital, she had already presented to premier institutes of our state multiple times, like 20 times. With obstipation, she was given conservative management and discharged back home. So when she presented, she had obstipation, pain abdomen, her abdomen was distended, tender, fecal infection. So you can see this was the CT picture. If some radiologists may be here or some surgeons who are familiar with the images, you can see the amount of fecal loading. Sorry to present this before dinner. So whole sigmoid, whole rectum, it's loaded. It were like tons of stool stuck there. So we admitted her that time and into the ward. Later, in the ward she got sick. Actually, she had pulmonary embolism. This huge sigmoid was sitting on the iliac vessels, giving rise to this DVT and then pulmonary embolism. Thanks to our great team in ICU, our cardiologists who managed it. So, and our nurses who worked like for 2-3 days to evacuate it manually. I had taught a lot of pizzas and burgers for them, for our nurses. So after 2 months, we got her back and got PSC done. Our gastro people, Dr. Adil sir and Dr. Wajid sir, they did the endoluminal work. And we in this MDT meeting, we decided to go for laparoscopic sigmoid resection. So the diagnosis was made redundant sigmoid with mega sigmoid and mega rectum. So I will play this video, how we do it. Sorry. Volume. Icarus volume.
Volume. See hugely dilated sigmoid colon.
Just 1 minute video, huh, sir?
Pretty long and redundant mesentery. We started our dissection medial to lateral. I prefer doing it with electrocautery monopolar hook. Key is to identify the bloodless plane. We continued our dissection medial to lateral to identify ureter in the retroperitoneum. You can see the peristaltic tubular structure in the background. It's a key step in all left-sided procedures. Well, dissection of inferior mesenteric artery. Since this was benign case, we spared left colic artery and started our division beyond the origin of left colic artery. Application of Hemalox, 2 towards specimen, 2 towards body, and the division.
Another just 1 minute video.
Vasculature, we continued our dissection of the lateral attachments of the colon. It's quite satisfying doing it with a monopolar hook. Preparation of the rectal stem for application of the staplers. In this case, we had to fire at least 6 staplers. In a normally we just require 1 or 2 because this was hugely dilated sigmoid and first part of rectum. Delivery of specimen and placement of anvil. Introduction of circular stapler through anal route. Engagement of the anvil and firing of circular stapler was done, and anastomosis made. Leak test was done on table, no leak found. Well,
this is the picture of this when we take out the anvil, the ends of the rectum and descending colon. This was the specimen. Hugely dilated sigmoid. I never seen such a large sigmoid in my life. So this was the final picture of the abdomen. Thank you. Any questions? Thank you.
Anybody having any questions to sir can ask.
Thank you. Thank you for not asking questions.
Things are top-notch work that is going on in Paras Hospital. Now I'd like to invite Dr. Naeem Firdaus Dar, Senior Consultant Pulmonology, for a short interactive session. Just a short interactive session, sir. Not much.
उस टाइम भी मैंने जो टॉक दिया था इट वाज रिगार्डिंग हाई ऑल्टीट्यूड पल्मोनरी एडिमा विच वाज रिलेवेंट टू दिस स्टेट एंड यहाँ से जो भी मेरे पास पेशेंट चाहे मैं पार्स में देखता हूँ या आज के ओपीडी में देखा तो ब्रोंको एंथ्रोकोफाइब्रोसिस एक प्रेवलेंट एंटिटी है जो यहाँ पर पाई जाती है। तो इसके रिगार्डिंग थोड़ा सा मैं बताना चाहता हूँ कि इन पेशेंट्स को अर्ली पिकअप करना है। इन पेशेंट्स का अर्ली डायग्नोसिस एंड ट्रीटमेंट बहुत ज़रूरी है because mostly this disease is present in elderly females और इसका जो कॉज है बायोमास एक्सपोजर है जो अर्ली पीरियड्स ऑफ लाइफ में होता है। तो एक्चुअली होता क्या है इसमें इट मोर और लेस बिहेव्स लाइक COPD। दे विल कम टू यू विद ये ब्रेथलेसनेस करके सिम्टम्स आएंगे आपके पास, छाती में पेन के सिम्टम्स करके आएंगे एंड सम ऑफ देम कैन कम विद हेमोप्टिसिस। सो अर्ली पिकअप ऑफ दीज पेशेंट्स इसलिए ज़रूरी है बिकॉज they are the patients who present sometimes with massive hemoptysis and they can go in suffocation and result in mortality. Second, these patients if not monitored over a period of time they have a predisposition to malignancy also. ठीक है. So what we do by diagnosing these patients, we treat them in the same manner as we treat COPD patients. We follow them yearly with a pulmonary function test, and sometimes when we feel there is increase in symptomology, or if there is new occurrence of blood tinged sputum, that time we go for CT scans. In CT scans, if we feel that patient is having increase in the lesion because they present with mass like lesions in the CT, so we have to suspect these patients may be pre-malignant, and bronchoscopy in these patients at that point of time becomes mandatory. So what we see in bronchoscopy in these patients, वो वीडियो प्ले कर लो प्लीज. What we see in these patients during bronchoscopy, there is mucosal and submucosal infiltration of black tar-like pigmentation, and sometimes this tar-like pigmentation they cause ये bronchostenosis करते हैं. When there is bronchostenosis, that means the air is not going far behind these bronchi, and it presents like a mass-like picture. So this is one of the patients. Just before coming here, I did this on I think Friday. This patient, you can see this blackening there, and you can see the right upper lobe is completely black. You see these black, this all becomes, so these are the इन्हीं जगहों से फिर hemoptysis produce होती है. So my message to you people is that COPD patients should be under surveillance, and female patients with COPD should be monitored for these things. Hemoptysis should serve as a alert alarm with these features on the CT. See, you can see the left upper lobe in this patient was completely obliterated. So I had a plan that I will go inside, take a biopsy, because it was looking like mass, but when I went inside, we just visualized the bronchi and we came out. Just touching these lesions will spurt into hemoptysis. So we don't even take ball in these patients sometimes. So that's what was my message today. And फिर से एक बार मैं यहाँ पर इसी बात से अपना टॉक एंड करूँगा कि regarding interventional pulmonology, we are equipped with all sorts of modern equipments in our hospital, whether it is EBUS, whether it is radial EBUS, whether it is thin bronchoscope. We can go to the peripheral nodules, and we are 3 consultants working there, me and other 2 colleagues, Dr. Zubair and Dr. Yusuf. We are almost doing all the procedures in our hospital. So any timely referrals, whether it is a lung mass, whether it is a peripheral nodule, whether it is hemoptysis cases, we will welcome that. I am thankful to Dr. Vilayat and Dr. Ghulam Hassan for their referrals, and we have been trying to satisfy the patients as well as the referrals from this place. Thank you very much. Treatment of bronchodilator and sometimes steroids, since it is a bronchoanthracophibrosis. You have seen IPF patients. In IPF, we are using 2 antifibrotics like perfenadone and nintedanib. These patients, nowadays, we are trying to use antifibrotics. Why we are? It will not reverse them, but there is an angiogenesis going on in these areas where this is anthracosis. So to decrease that angiogenesis, we are using the antifibrotic agents. It is not documented, but we are using it. We have started using antifibrotics in these patients. Any other questions? And patients with tuberculosis, post-tubercular fibrocavitary disease, they are also the high-risk patients which should be monitored for this BAF. Chaliye ji, thank you very much
for giving such insightful talks. We are now at the end of the session. The talks have been finished. Now we have a short ceremony. I'd like to make an announcement. Recently, we launched a much needed initiative in Kargil. A cancer society was lacking in our district. So recently, Bakaria Healthcare Research Center Kargil launched a cancer society with the name of Cancer Society Kargil. To distribute, the facility director, sir, please come forward and present certificate of nomination and appointments to our executive members and other board members of our Cancer Society Kargil. First of all, I'd like to invite Dr. Vilayat Ali, a senior physician Kargil, who is president of the society. Dr. Vilayat Ali, consultant, senior consultant physician. He'll be working as president of the Cancer Society Kargil. And after that, Dr. Sajjad Hussain and Dr. Imtiaz Ali. Please come forward. Dr. Sajjad Hussain will work as Vice President of the Cancer Society Kargil, along with Dr. Imtiaz Ali, who is not present today. So he will, Dr. Sajjad accept Dr. Imtiaz sir's certificate also. And after that, I'll invite Dr. Iftikhar Ali, who is a consultant pediatrician, and Dr. Nooreen, consultant ophthalmologist. These two doctors will work as clinical coordinators in the society. Dr. Nooreen Batul, consultant ophthalmologist, District Hospital Kargil, will work as clinical coordinator in Cancer Society Kargil. After that, Mr. Gulzar Hussain Danish, he'll be working as General Secretary of the society. Dr. Alia Gul, I think she's not here. Dr. Alia Gul will be working, she's a consultant pathologist, and she'll be working as the spokesperson, along with Dr. Razia Banu, who is a consultant surgeon. She'll be again working as a spokesperson. Dr. Farida can accept their certificates on behalf of these two doctors. Mr. Mohammad Ibrahim. After this, Mr. Mohammad Ibrahim is present here. Please come forward. He'll be working as joint secretary of the Cancer Society. After that, Mr. Mohammad Hussain will be working as treasurer. Mr. Mohammad Hussain. Now we have board of executive members and advisory board. I'll announce their name. Please come forward to accept the certificate of nomination. Dr. Shazia Naz, consultant anesthetist, District Hospital Kargil. Dr. Asif Hussain, anesthetist, District Hospital Kargil. Dr. Manzoor Hussain, consultant radiologist. Dr. Saeed Abbas, consultant orthopedician. Dr. Chozom, medical officer. Professor Nasir Shabani. In the advisory board, we have very senior members. Dr. Ghulam Hussain Bardi, who is a senior consultant physician. He will be the chief advisor to the society. Dr. Ghulam Mohammed, senior consultant pediatrician advisor. Dr. Muhammad Ibrahim Khan, ex-assistant director, will be again an advisor. Dr. Ghulam Mehdi, sonologist. Please come forward, he present here. Dr. Idrat Hussain, maxillofacial surgeon. Dr. Amina Banu, anesthetist. Please come forward. She'll be again an advisory member. And we have one more member as a manager, Mr. Fazil Abbas. On behalf of Mr. Fazil Abbas, thank you so much, sir. Now I'd like to invite Dr. Murtaza Habib, Facility Director, Paras Hospital, to say a few words and encourage us volunteers and doctors also.
I know everybody is already tired of waiting. I'll be short. Before thanking everyone, I would shortly tell you in like 2 minutes about Paras. Paras Srinagar is already 2 years old. Organization around 20 years old. And out of these 20 years old, I have been with Paras for 5 years already. The main aim of Paras as an organization is to set up tertiary care hospitals in tier 2, tier 3 cities. So cities like Srinagar and smaller cities as well. And to really do this kind of work, the tertiary care kind of work, these platforms and these connections are important, necessary. So I would, with that note, thank everyone who has organized this, the Bakaria Society, the Trust, the important members here, and our doctors also for making it possible to travel and to share knowledge and do the camp. Thank you. Let's enjoy the dinner, please.
Thank you so much, sir. On behalf of Bakaria Healthcare Research Center, KARGIL, I'd like to thank our visiting doctors, expert doctors, along with the managerial members. For giving a formal word of thanks, I'd like to invite our president, Dr. Ahmad Ali, sir, to formally present word of thanks and thank everyone associated with the camp and this CME.
A very good evening to all the delegates here. कहने के लिए कुछ नहीं है सर, बस thanks on behalf of Bakaria Healthcare and Research Center Executive Body and members. Thanks to the visiting team from Paras Health, all the way from Srinagar. अब ये second time है, तो I hope कि winter में और एक बार डॉक्टर नहीं तो इन्होंने तो वादा किया ये आ जाएंगे. तो rest of the young doctors, I hope they will definitely visit here. तो आज डॉक्टर मुर्तज़ा भी आए हैं, तो आई वॉज एक्सपेक्टिंग योर विजिट लास्ट टाइम ऑल्सो, बट यू मिस दैट अपॉर्चुनिटी सर एंड वी टू. तो मैं अपने डॉक्टर्स को, मैं अपने कोलीग्स को, अपने सीनियर्स को थैंक्स कहना चाहूँगा. यहाँ पे आए इस शॉर्ट नोटिस में आप लोग आए और इस इवनिंग को आप लोगों ने इतना खूबसूरत बनाया. ये चूँकि हम कट ऑफ तो नहीं बोलेंगे, बट यस, एकेडमिकली वी रिमेन कट ऑफ फ्रॉम रेस्ट ऑफ द वर्ल्ड. वी डोंट हैव सच फैसिलिटीज़ हियर जैसे हम अपने पोस्ट ग्रेजुएशन के टाइम पे CMEs अटेंड करते थे, सेमिनार्स अटेंड कर. वी डोंट हैव दोज फैसिलिटीज़ हियर, बट वी ट्राई टू प्रोवाइड दीज थिंग्स विद सच CMEs. तो ऐसे CMEs को अटेंड करना हमारे लिए अच्छा है और वी गेट अपडेटेड विद रिसेंट नॉलेजेस एंड मेडिसिन इज सच द थिंग दैट पलक झपकते ये चेंज होते रहता है. तो मैं अपने डॉक्टर्स को शुक्रिया अदा करना चाहता हूँ. कोई आप लोग यहाँ आए, हिस्सा लिया, पार्टिसिपेट किया, एंड यू आई होप कि यू गेट अपडेटेड विद द रिसेंट नॉलेजेस. और ऐसे जो रिसेंट अपडेट्स इन्होंने दिए, आई एम हाईली थैंकफुल टू द डेलीगेट्स फ्रॉम पारस. तो आप लोग इंजॉय कीजिएगा. आई एम हाईली थैंकफुल. मैं थैंक्स करना चाहूँगा डॉक्टर मुर्तज़ा सर आपका, आप यहाँ आए और जो MOU हमने साइन किया है वो ऑपरेशनल है. होप की कैंसर सोसाइटी डॉक्टर विलायत, लेड बाई डॉक्टर विलायत, तो इसमें भी आप वो MOU साइन हो जाएंगे. आई एम हाईली थैंकफुल टू मिस्टर अरुण एंड इकबाल. ये दोनों बहुत मेहनत करते हैं. तब बिलाल इज मिसिंग दिस टाइम. तो इकबाल तो बिल्कुल बिजी रहता है सर. ही इज़ अ वेरी हार्ड वर्किंग पर्सन. आई डोंट हैव वर्ड्स टू एक्सप्रेस माई ग्रेटिट्यूड टू मिस्टर इकबाल एंड मिस्टर अरुण सर. आप भी बहुत ही मतलब सर आप बहुत दिल लगा के काम करते हैं. आपके साथ ऐसे टीम है डॉक्टर मुर्तज़ा सर. तो आई होप कि ये हमेशा आपके साथ रहे और हमारे साथ रहे. थैंक यू. थैंक्स फॉर एंजॉय द डिनर प्लीज.
बोलना था मुझे, आप लोगों ने सेट करी है, दैट्स अ ग्रेट इनिशिएटिव. ऑन बिहाफ ऑफ पारस मैंने आज कॉर्पोरेट बात करी थी, तो वी विल एक्सटेंड स्पेशल डिस्काउंट फॉर कैंसर पेशेंट्स whoever comes for treatment to our hospital. We will soon sign that MOU separately, where we will give a greater discount to all cancer patients whoever are coming from your center or through your center or KARGIL to our hospital.
Thank you.
Thank you.
Enjoy the dinner. Thank you.